Hello everyone, thank you for joining this presentation. My name is Liana Ludmila Frutos, and today I'm going to talk to you about this research called Can CPOE based on electronic order sets cause unintended consequences, expensive and unnecessary tests at the emergency department? The purpose of this paper was to describe the ongoing system for CPOE order sets and to explore an economic evaluation of the emergency department. So before starting, I want to mention that this research is the product of collaborative work between the Health Informatics Department, of which I belong, and the Emergency Department of Hospital Italiano, Buenos Aires, Argentina. So this presentation is organized in 4 sections. The first is the introduction of the topic and related problems, then methods in which I will explain how we conduct these investigations, results, conclusions, and acknowledgement, of course. So I'm going to start with the introduction. Well, CPOE, computerized provider order entry, in healthcare has been introduced across the healthcare system based on a business model suggesting saving from improved patient safety. So historically, CPOE has been implemented in drug prescribing and has been shown to reduce medical errors and adverse effects, but less attention had been paid to the impact of CPOE in laboratory and images. And as all we know, the order sets have the potential to improve provider efficiency by conveniently grouping orders together, and also can influence provider behavior based on evidence. Despite this, we found that there are pros and cons regarding this issue, especially some unintended consequences of CPOE reported in several studies. On the other hand, we have the emergency department face significant challenge in delivering high quality and timely patient care on a never-present background of increasing patient numbers and limited hospital resources. So unnecessary healthcare utilizations and no adherence to current clinical guidelines or insufficient personalized care are a perpetual challenge and remain potential major cost driver for healthcare systems around the world. So many institutions invest in CPOE system with expectations that they will result in faster delivery of test results to physicians, and which will increase the likelihood of quicker diagnosis and treatment decisions, but there is not enough evidence about their efficacy in the emergency department. So we, as health IT professionals, play an important role in the implementation of systems that could solve many of the problems that I already mentioned before. However, if we don't evaluate the system implementations, we will never know if there are unintended consequences. And this is relevant because these types of consequences can trigger excessive resource usage and add unnecessary costs to the delivery of healthcare. So I will repeat again, but in this research, we aim to describe the ongoing system in electronic health record for CPOE order sets in emergency department settings, and to explore an economic evaluation of metrics and detailed cost components in order to rethink an effective way to eliminate waste and efficiency. So, well, method, the second part. Our study took place at Hospital Italiano, Buenos Aires, IVA. It has an emergency department that provides attention for unscheduled consultations 20 hours a day and 365 days a year. And actually, it has more than 500 visits per day, so it's a lot. The infrastructure consists of 4 areas of care, differentiated according to complexity, which is defining of the patient's conditions of admission. We conducted a cross-sectional study, which included all consecutive admissions from adult patients, I mean over 18 years old, to the ED emergency department between January and February of the last year, 2020. We use secondary databases with administrative datasets containing different variables like waiting times, triage classifications on arrival, time of initial provider examinations, medication prescriptions, tests with cost and prices, admission orders, and discharge order. So, well, results. Here, first we develop a cost dashboard which shows us the significant and excessive use of medical tests per consultation. So we decided to develop a cost dashboard that shows us a local and real-time data. And this dashboard, in fact, allow us to detect the top 10 most widely used and the top 10 most expensive tests. And in the graph, we notice that the lab seems to continually increase in every consultation. In other hand, our CPOE order set has been ongoing since 2012 and allows physicians to search for a study and practices predefined concept, which return results related to the fixed text entered. By class definition, an order set allows you to request all the practices or studies that it contains. However, in our case, the user, the patient, must select what they really want by clicking one by one from a menu of relevant order grouped by a clinical purpose. One additional functionality is to allow individual clinicians to develop their own private order set that they can use for their patient. So as we can see here, this is an example of an order set for our electronic health record in an emergency environment consultation, and it shows the practices containing the order set for, in this case, heart disease, specifically acute coronary syndrome. So during this study period, a total of 27,671 consults were admitted at the emergency department, and regarding the condition of discharge, only almost 9% were hospitalized. We explored some baselines, characters related to patients, shown in table 1, and as can be seen, almost 30% of the consultations have at least one item of laboratory practice with a median of 9 items. And in the other hand, 80% of the total cost for each consultation was explained by the cost of the laboratory. So in our discussion, our findings suggest that there is a significant and excessive use of medical tests in emergency departments, which could entail a potential waste of unnecessary and expensive resources. While order sets can save time and improve processes of care, it remains clear that order sets have shown definite patient outcome benefits. So the automation of order through such order sets or joint order options could lead to increase in cost, for example. The rate of unnecessary laboratory tests, can increase when healthcare professionals tend to accept the whole order set rather than the selected single order item. So, however, doing their own private order sets potentially removes the evidence-based nature of such order sets and can make it difficult for CPOE clinicians users to do the right thing based on evidence-based order sets. So a future line of the study will be to deactivate the CPOE order sets for the emergency department with the intentions of exploring whether this is associated with rethinking the individual clinical context of each person and consequently allows requesting fewer unnecessary practices. So our conclusion is that CPOE systems may cause unintended consequences, and the emergency department face significant challenge in delivering high quality and timely patient care on an ever-present background of the presentation numbers and limited hospital resources. So evaluating the economic impact of electronic health record-based CPI order sets interventions and their potentials to increase value in healthcare remains a significant challenge, especially in the emergency environment. So finally, I want to acknowledge all healthcare workers during the pandemic, especially those of the emergency departments, and all collaborators who provide channel support for this research. Well, I will be available for any questions, comments, or suggestions. Here is my email address. So thank you so much for your time and listen this presentation.